Welcome, everyone, to today's program. I am Laura Dierda with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following the completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. The email will not include the presentation. It is now my pleasure to introduce today's presenter, Chuck Micel. Chuck is the Vice President of Sales at Surgical Notes. Prior to joining Surgical Notes, Chuck was most recently served as Vice President of Business Development and Vice President of Sales for Poplar Healthcare, a physician-owned pathology laboratory services company. Chuck's extensive experience in the ASC setting provides him with an expert point of view of the specialized tools available to assist ambulatory surgery centers in running more efficiently and more profitably in the ever-changing healthcare industry. At Surgical Notes, Chuck is further developing the sales organization and is committed to providing solutions that cater to clients' specific needs and helping strengthen relationships with existing clients. It is now my pleasure to turn the floor over to Chuck to begin today's presentation.
Thank you, Laura. Good afternoon, everybody on the East Coast. In the central United States, it's around brunch time, and in California and Hawaii, it's still in the morning. My name is Chuck Micel, and I appreciate the time that you allocated to me this morning. Before I kick it off, I'd like to review what the agenda looks like for approximately the next 35 to 45 minutes, and the definition of the products, legislative update, what you'd like to achieve, the evaluation of different competitive products and solutions, what can I afford and how do I get owners and or management partners to approve, how do I prevent or reduce the potential for making a mistake, the buying process, creating your own return on investment or using a vendor's tool, and then questions, and then hopefully good answers at the end. But the intent of today's webinar isn't to sell you something, but really to help you have better tools to assess where you want to take your center in the future. What are the dynamics? How can you be better prepared as we migrate into a more electronic future? We've all had buyer's remorse at one time or another in our lifetime, and hopefully this will reduce the likelihood that you could have remorse tied to selection of an EHR in the future. So to kick it off, from a definition perspective, everything we're going to be talking about is an electronic health record. And from a definition, it's an EMR plus an EMR or an EMR and any other patient information system, like your scheduling and billing system. That equals, according to the definitions, an electronic health record. An EMR is an electronic version of the patient's chart. For all intents and purposes, what we're going to be discussing today is an EHR. Additionally, from a definition perspective, understanding what discrete and structured data is going to help you tremendously. This is the information that when it's entered into the EHR becomes queryable. And the difference being is when you're charting on paper, pen isn't discrete data. You can't mine it. So the code is in the background within the EHR and is transferred to other systems so that other clinicians somewhere else know exactly what was meant, but you can also then mine this data, and create structured reporting elements that are going to be at your fingertips. So, for example, capturing the quality measures that CMS requires would be a structured and/or discrete data that you would have at your fingertips to report on a monthly basis. Or if you have a corporate partner, they would be able to access this information remotely. From a legislative update, today there's not a requirement for licensed surgery centers to have an EHR, nor has CMS indicated they're going to mandate surgery centers to implement EHRs. And today, there's not an approved meaningful use standard for surgery centers. There is for the physician market and in the acute care space where there are incentive dollars tied to achieving meaningful use. There was a bill that was introduced, and it's the Electronic Health Fairness Act of 2014. And ASCA was really the driver behind this. And the intent is to make sure that ASC physicians aren't penalized because they don't have an EMR within their surgery center and they're unable to meet the criteria that is in the meaningful use bill. And to date, and in my conversations with ASCA, and they continue to keep everyone updated, we're not aware of anyone that has been penalized because they do not have an EHR at their surgery center. In fact, last week, this just came out, tied to a working committee to really see what they can do, because this goes back to the Stimulus Act. And after $28 billion in taxpayer dollars being spent subsidizing EHRs, finally the government has realized that maybe they're not getting the bang for the buck that they thought they were going to get. So the goal of the working group is to identify 5 or 6 things that can be done to help make the failed promise of EHR something that physicians and providers look forward to instead of something they have to endure. And this ties into a bigger picture tied to when we look at the total expense. If we were to move to this type of a product, to an EHR within the surgery center, it's a big expense, but it's got to work, and we're going to talk about the ways to make it work. I thought this was kind of appropriate given the fact that that announcement on the working group came up last week. And the reality is where the rubber meets the road is where it has to work at the center, at the practice, and at the hospital level. So when we look at our business today, each of you does a tremendous job making sure that your centers are profitable, well-run, safe. The reality is you have better outcomes with fewer complications at a price point that can't be beat. So when you look at what makes you successful, it's those efficiencies. It's everybody doing the right thing at the right time with the patient in mind. And you're profitable. I mean, distributions are being made. Centers continue to be acquired. National chains are continuing to grow through acquisition. So probably now more than ever, it's imperative that the IT purchases that you're contemplating make sense financially and increase the bottom line of the center within a 12 to 24-month period at the latest. So when you look at why you're looking at an EHR, and these are comments that I've heard over the past couple years, and some of these are very, very recent. I'm going to have to get one anyway. There's going to be legislation, or everyone has one, or I'll be penalized for not having one. And some of these are true. I'm going to have to get one anyway. Perhaps everyone has one. Not necessarily true. It's about 10 to 15% of the market has an EHR today, and I'll be penalized for not having an EHR. There's been no legislation introduced to penalize anyone. Your driver for getting an EHR should be basically these 4 bullets here. because it will increase the profitability of your center, because it will reduce your labor expenses and save your facility money. It'll free up your staff to improve patient care and interaction. And it'll enable you to report on your clinical outcomes, which should result in increased reimbursement and or profitability. However, given the fact that we're surgery centers are episodic sites of care, it's really so important for it to improve the profitability by eliminating and reducing expenses. For example, you wouldn't buy GI equipment, new scopes, new monitors, etc., in the hopes that gastroenterologist is going to come to your center. You'd have done the return on investment tied to reimbursement and have assessed, hey, by bringing this equipment in this number of cases, we're going to end up with this much revenue and this much profitability, which will pay for the system. Same thing that you need to do when you're looking at in terms of buying an EHR. So when we look at why we chart, it's to document what our nurses and physicians are expected to be doing. It's a checklist. We do it in sales. We do, when I was in the military, we had numerous checklists tied to different operations. Pilots do it, sports teams. It increases safety, bottom line. AAA, Joint Commission, the surveyors, they want to see and validate that that your staff is doing what they're supposed to be doing. It's also used to demonstrate that the policies and procedures that you have in place were adhered to in the event that there was a sentinel event. I mean, today, there are roughly 50,000 paper charts being created in surgery centers, and probably about 5,000 to 7,500 electronic charts. The question is, can charting be done electronically in a manner that is efficient, cost-effective, eliminates all the paper, is easy to use, is IT supportable, and captures the discrete data you need? And not only do I think so, I know so. But it's not necessarily super easy. So what am I trying to accomplish by implementing an EHR? I'm improving on a current process that we know works. I'm going to reduce expenses. I'm going to lower my cost per case. I'm going to have better business analytics and increase patient involvement, as well as perhaps more involvement from the practice. Am I replacing an outdated, i.e. no longer supported solution, or a poorly performing technology? And then how do I go about it? So when you look at the healthcare IT buying cycle, you've got a discovery phase, an investigation, comparison, justification, implementation, and optimization. For sake of argument, I would probably say the last three are probably the most important, but if you make mistakes on the front part, the justification, implementation, and optimization will be a challenge, no doubt. So when you look at the discovery, and I think everybody today is in a discovery mode. When you're looking, and you are virtually all the time. What products are out there that we could transform? What could we replace an existing product that's holding us back? And one of the great ways to do that, we've got it coming up later on this month, is the ASCA conference. What's new? You're talking to lots of peers at the same time, and see what's out there. What other centers in your specific area have a product, and is it a competitive advantage that you don't have? I.e., are they more profitable because of that solution than you are? The other thing to do is pick someone at your center, if not yourself, to become that discovery person. I mean, you as an administrator, business office manager, or director of nursing, perhaps it's time to delegate and have somebody on your team that might be a little bit better at researching those types of things. Phase 2 investigation. We've already identified the issue, so now it's isolating and coming, putting together that short list of products. We talked about what are the other centers using. Begin by examining all the expenses that you want to impact. So, for example, your paper expenses when we're talking about charting. And when we say all of them, I mean it's every aspect of that. It includes the labor that goes into it. It's the overtime. If you guys drill down, do you understand what your cost per chart is? All bundled together. All the paper, the toner, the labor, the charts themselves, off-site storage, on-site storage, etc. Basically, and I've heard this from different folks throughout the market, they've tied roughly about $10 to $15 per chart, all in. And so for, if you split the difference there, you're looking at about $12.50 per chart. When you start looking at comparing the solutions that are out there, how do you go about evaluating, comparing the vendors and products? I would recommend that you request a demo or presentation. It can be done easily via the web. Get your owners and partners knowledgeable. Let them know what you're looking to accomplish. I'm sure they're going to want some involvement on a final decision, particularly if it's a significant financial investment. Establish a budget. Determine what the soft costs and hard costs are tied to implementing a solution. Because, I've talked to enough centers out there, and they're like, wow, if I'd known it was going to be that much from an ongoing support or maintenance, I wouldn't have gotten. Create a list of the capabilities that you want the solution to have versus those that are nice to have. And I've created a rough list on this slide and kind of the must-haves. And when I talk about ease of use, I've never met a salesperson sell something that was hard to use. And believe, I know there's hard to use products out there because I've purchased some of them. But from an ease of use, it's got to fit into your workflow. Is it using basically your current forms, but in an electronic digital modality? You also want allergy alerts throughout the chart. You want it to completely eliminate paper. And I have in parentheses here, no thin charts. I've been into surgery centers, and there's probably some folks here on the webinar that have an EMR but still have paper charts. And it's a thin chart because maybe all the clinical documentation and pre-op and the OR and recovery is done on a different product, but there's still a paper chart that flowed along with it. And it could include the H&P that came from the practice. It could include other documentation, but you want a solution that's going to eliminate all aspects of that chart. You're going to want your operative reports to flow directly into the chart so that your billing folks have access to them. You want automatic chart auditing capabilities. Soft and hard stops tied to missing documentation. You can't go on without certain elements being documented. You want to have an easy-to-use standard report generator that can be customized by a layperson. So you don't have to have a PhD in crystal reports. Something that where your physicians can add their post-op note to the chart easily, whether they can voice dictate it into it or they've got a simple template that they can add to it so it's in there. A hosted solution as opposed to a server-based on-site solution. And we'll talk a little bit more about that as we dive into the presentation. Another thing that I have is the subscription model. We don't know what's going to happen. We see hospitals continue to buy surgery centers or turn them into an HOPD model. And in those types of solutions, when things like that take place, you don't necessarily want to have a super expensive system that you just acquired 18 months ago and you're going to try and have to migrate to something else. So a subscription model reduces that risk. Tied to paper chart, anesthesia has to use it. If they don't, you're going to be back to paper within the OR, and then you're going to be having to scan the anesthesia notes into the electronic chart, and we don't want that. And last but not least is interoperability. There's a lot of different ways to scan the CAD on interoperability, and it could be from the physician's office back to the center, or from the center back to the physician's office, or if there's a hospital relationship, getting information to that hospital tied to that patient. On the nice to have, and I'll just read through these quickly: auto vital sign capture, iPad or tablet versus laptop or computer on wheels, e-prescribing, drug library, internal messaging throughout the center, image capture from your processors and towers, patient status visible on monitors in a waiting room, a patient portal, remote access, and also that, hey, what you select could be standardized among 2 or 3 centers as your business continues to grow and you add a second or third surgery center. When we talk about, and that was just a little bit on the comparison criteria, from a justification, this is where you're going to be convincing your physician partners that, hey, this is the route that we need to go. You've got to validate that return on investment as best as possible. You've got to really have the hard conversations tied to current clients and conversations with customers to confirm or refute their ROI. Because they could say, wow, we really love our EHR, and then when you ask the question, hey, has it paid for itself? And they go, no, actually it hasn't. And if this is 2 or 3 years in, that could be a red flag, and then maybe that's going to change your decision making. When I talk about kind of protecting yourself, I would obtain performance criteria in writing in your contract and include an agreement with the vendor that the product will meet, fairly simple standards. For example, that it's going to eliminate 95% of all your paper. And if it's not able to, what's the penalty for that? That it's going to be operational 99.9% of the time. That if they make an upgrade to it, is that upgrade included in the cost of the system? If they say that an enhancement or feature and capability will be available in the future, get that in writing. And then if it's not, tie a reduction to your annual maintenance. If you have that included, have it reduced by anywhere from 5 to 10% because that feature is not yet available. When you look into the go live, you've purchased it. Now the process is really shifted to completing a smart, successful implementation that your team is all on board with. The trainers are doing a great job from the company that you picked, and that there's minimal impact on your day-to-day business. The reason I bring up minimal impact is because if you have to cut back and go to 50% of your standard number of cases per day, and you do a fair amount of orthopedics or other cases where there's a lot of add-ons, you may not be able to add those cases on. And just like when your center's closed because of inclement weather or snow, those orthopedic cases that were added on, they're going to be done. They're going to be done at a hospital, or they're going to be done somewhere else. So you've got to really think about, hey, we want to go live, but we want to stay as live as possible at full capacity. Is my staff ready and supportive? Who's my go-to person in-house? If you identify, is that super user somebody that's going to be with your center a long time? Because I've also been in centers where the power user changes. And if you don't have somebody ready to step into that role at the center, then the system becomes less effective. Again, keep your physicians up to speed. One other thing tied to implementation and ease of use is if your center's in an urban setting versus rural setting, I'm willing to bet that you have more staff turnover. If in Durango, Colorado, people live there and are pretty much permanent. In Dallas, you're looking at staff that is, I mean, there's a lot of different surgery centers there, and it's hard to keep people, staying at the center for a long period of time. So which ties into your EHR selection, in that, is it really easy to use? Can my staff pick it up quickly? Is it just like charting on paper? Something to think about. The sixth step, optimization, and it never ends. This is tied to product enhancements, capabilities, new interfaces, changes in your staff. Again, if you have people leaving, so you want constant optimization. Are your annual expenses tied to your EHR? Are they going up or down? Because if they continue to creep up and you're not getting the bang for the buck that you expected, maybe you need to look at something else. If the product isn't working, is it not worth the annual maintenance? Is the company supporting the product and honoring their commitments? So important, because you don't want to be that center with buyer's remorse. And again, keep your physician partners aware of everything going on with the system. Oh, they'll hear it, I'm sure, from the staff. Some return on investment measurements. And I didn't put together a full-blown return on investment, but just a couple things to think about when you're assessing, hey, what am I buying? And I put together two different options here. Number one is you own the software. You've purchased that license, and it can be based upon number of users, number of ORs, number of procedures, etc., or it can just be a flat price. Every company out there does it a little bit differently, versus a SaaS model or software as a service, where it's a subscription. It's an annual expense. So within buying the software license, you got your software that you own, and you own it as soon as you probably sign the contract and they send you a link to the software. Boom, you own it. That's when maintenance starts. You got your training expenses, hardware expenses, and typically in this type of a model, it's much more IT hardware supported, where you're going to have on-site server. It's going to be more computer on wheels typically, and then you got your support. You got your software maintenance, as well as who's going to provide your local IT support. You may have your own IT team. Most centers don't, or you rely on somebody from corporate if you're part of a management company. And you'll probably end up having to pay for those elements. You have travel for your implementation, tied to what your savings. What's my elimination of all my paper? What's my elimination of storage expenses, labor savings, reporting savings? On the subscription model, again, the software is an annual expense. You're still going to have the training. You're still going to have hardware, although it's going to be substantially less. It'll probably be more on tablets or iPads. You're still going to have the travel expense. But what you won't have typically is that software expense, because your maintenance is included in your annual subscription. So you can, literally compare these side by side. And then on the savings, they're identical to if on the purchase software license. So when you've done your return on investment, and hopefully you're going to end up in the black based upon your analysis, and just in a rough pro forma here that I've done, this particular center was in the black over a 12-month period, $38,000 in savings to the center. At an average of $350 in net profit per case, that equals 109 new cases on an annual basis for that particular center. And in a center that averages 300 cases per year, that's a 3% increase in case volume for that year without having to go out and find an additional 109 cases. And those 109 cases didn't come with, they came without labor, It came without supplies, etc. And if your physicians are contemplating or considering selling a portion of the center at some point, that $38,000 in added net income ends up becoming $114,000 if they sold 51% of the surgery center, and if the multiple was 6. So you can see, like, right now, if you were going to grow your center by 3% with organic growth, coupled with this, you're looking at a 6% increase. So this is benefits the center tremendously. Conversely, if you add a technology that doesn't benefit the center, that becomes a financial drain, it's going to be that much harder to make up that lost revenue, because now you're going to have to, if you were down 38,000, now you're negative 3%. To get back to the whole, you're going to have to grow it by 3, and you'd have to grow it by 6 to net a 3% increase. So just some additional things to contemplate. You know, in conclusion, you and your staff should determine what's best for your center and or centers. Really do your due diligence. Pick a solution that pays for itself, not the other way around. Something else here is you're going to have to make some compromises. That EHR that is perfect, I don't think it exists. Or if it does exist, it may not be at your price point, or it's just not available yet. In the end, I think we'll all, and this is said in jest, is that we'll all end up using what the government decides on anyway. But in the meantime, let's pick the products that work best for your center, for your staff, and for your physicians. I've never seen anybody throw a keyboard through a monitor, but I have seen a physician throw a mouse before. Fortunately, it didn't hit the screen, and it wasn't repairable, but so we couldn't resuscitate the mouse, but we did have a replacement. So I thought this was a little appropriate. Hey, there's a lot of change ahead. We'll continue to be there, and I'm sure you guys will too. I really appreciate your time. At Surgical Notes, we provide a number of different products and services to the market. SN Chart is our web-based transcription and management system. SN Coder, our full-service coding and integrated coder platform. ScanChart ASC, which automates the chart-making process and document management and turns your charts into an electronic medical record. And we've got ScanChart Central Billing Office, which ties into ScanChart ASC. And we have ASC Cloud, an EHR specifically designed for the ambulatory surgery centers. Please visit us at ASCO. We're at booth 418. If you want to learn anything else about Surgical Notes and the products and services that we provide, please hit our website. Today we work with over 650 surgery centers across the country, providing services that eliminate labor and expenses while accelerating revenue capture. And here's my email, our phone number. My email is cmeisel, MEISEL, at surgicalnotes.com. I appreciate your participation in today's webinar, and I'm sure we've got some questions out there.
Thank you, Chuck, for the very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and will follow up on questions they do not have the opportunity to address. And I do have a few questions here that came to us throughout the presentation. So, Chuck, the first one I have here is, what are the ROI drivers, typically hard or direct value and soft indirect value drivers for EHR?
Can you repeat the question one more time, please?
Sure. What are the ROI drivers typically for the EHR, whether those are some of the hard or direct value you have as well as the soft or indirect value? What kind of drives that?
Well, on the hard side, the center has the ability to look back at what their expenses are, tied to, hey, just the paper that's used in creating those charts, the toner, or if you're using an off-site forms company, and you're spending $2,000 a month on that and $24,000 annually. Those are the harder costs. Those are the ones that, hey, you can figure those out because you write a check. Where the softer costs are more on the labor, and it becomes to a redeployment. So today, if your staff has 2 people and they spend approximately 3 hours putting together charts, what are you going to be able to do? Are you going to redeploy those folks, or are they going to leave early? If chart preparation kind of takes place from 2 to 4 p.m. and now they don't have to, are you going to redeploy them? Or are you going to send them home earlier? So a couple different ways to look at that.
Absolutely. Perfect. And then the next question I have here is along the same lines. For software that an ASC would purchase, at what point after it's purchased should the ASC expect to be charged for the support fees? Would that start once the software was purchased, or when they're receiving training, or after they've reached the go-live date?
It depends on the contract, all right?
Okay.
And as a consumer, and with ours, it's tied to maintenance begins once you've had first successful use. So once the product's gone live is when maintenance would start. Again, it's going to vary by the vendor that you work with. Sometimes it's upon your acceptance of the software electronically. Other times it's when the product's been installed, or the other ways I've seen it is upon first productive use, and that's what I would recommend. And maybe if some of my competitors are on the call, they may not like that, but that's I think the best way to do it. And as the consumer, you guys are in charge of that.
Absolutely. The next question I have is, typically would bringing an EHR in eliminate the need for a medical records person?
It should.
Okay.
Because now what you're not going to have going forward is you're not going to have somebody who's physically assembling those charts, pulling them, reassembling, etc. You may have some other elements that, so for example, where let's say a pathology report needs to be added to the chart. There's a couple different ways to do that in an electronic scenario, but you're going to have somebody do that. And whether it's drag and drop from a desktop into the patient's chart or scan it into that patient's chart, you're still going to have that. But the reality is with a successful implementation, you're going to have eliminated pretty much that person's role, where you're going to be able to redeploy them into something where you're going to need more expertise.
Absolutely. Okay. Next, could you explain in detail how an EHR can lower the actual cost per case besides the administrative duties?
Sure. So going back to what is my cost for that chart? And if we use the number in between the two of $12.50, and that $7 of that is made up of paper. That becomes your hard. I mean, that's what I'm eliminating. I don't need that $7.50. The $5 in the labor component is tied to how you're going to implement or re-task those individuals that before we're doing that. I mean, think about how much auditing takes place, and we've all seen the nurses reviewing, doing chart audits and going through and making sure everything's been completed appropriately, etc. Or we've seen the box of charts where they need to be re-sticky labeled because the middle initial was incorrect, where there was something wrong tied to the patient identifier, so you needed to correct it. So there's a lot of different ways to look at that.
Absolutely. Okay. And then next question I have is, coming from a pen and paper-based system, what is the average time or labor savings you can expect by implementing the EHR?
That's going to be very dependent upon two things. It's going to be dependent upon your center's case volume, how busy you guys are, but it's also going to be dependent upon the specialties. So, for example, you know, if you have really thick charts, and you're doing 500 cases a month, you've got a lot of medical records folks. You've got folks that are assembling charts, you know, a week ahead of time on a daily basis, and then you've got your nurses doing pre-call, etc. You know, I would look at about a savings of about $12 per procedure for that individual center. So if you know you're doing 5,000 procedures a year, which is big, don't get me wrong, that's a big center, and you're saving $12 per chart, you're going to be saving about $60,000 annually. So that's the number to work with. Hey, if I bring in a system that is less than that, then I'm going to be in the black. And that's a very, very simple ROI way to look at it.
Absolutely, that makes sense. Perfect. And I have a couple of questions here as well about the surgical notes product in particular. Does your EHR include any documentation tools for the surgeon, or are you relying on the physician's surgical notes via the dictation, or is it surgeon's responsibility only?
I think the question is, can an EHR incorporate the physician's operative report into it? Can you repeat the question one more time?
Yeah, I think essentially this attendee was wondering whether the surgical notes EHR included any documentation tools for the surgeon.
Yeah, and it does. However, there's a little caveat there. It's not going to, I think for the simpler cases tied to cataracts, maybe GI, but definitely pain, where you can create a template within the EHR where the physician can create their own operative report where it can go directly to a coder. That as well as having a brief post-op note, which is required today in all paper charts, where the physician has a very, very brief summary of what they did on that particular patient as they await a full operative report that then becomes part of that chart. But I don't. We won't. With our product, it won't be for orthopedics or general surgery or the more complex. We're still going to be in having physicians use our transcription services where we can sync that operative report directly into the patient's chart and access to their coders and billers.
Got it. Perfect. All right, and then the next question I have here is, does Surgical Notes provide a financing option when selling their product?
We do. And well, first off, with our EHR, ASC Cloud, it is a subscription model. So in that sense, it can be paid annually or it can be paid monthly, but you're looking at a fixed operational expense as opposed to a significant capital investment. So we do have that capability to make it, and our goal is to bring those operational expenses beneath what you're spending today, so it's in the black as soon as possible.
Absolutely. Okay, let's see. And I have another question here, switching gears slightly. But I was wondering if you could give us your update, Chuck, on whether there are any ASCs will get a tax break if they install an EHR?
I'm pretty confident. If I was a betting man, I'd put a lot of money on no, and I don't gamble, so because I hate to lose money. But the reality is particular given what just came out last week with Senator Alexander, they're not happy with how much we've spent and the products that are out there and the lack of interoperability. So I don't anticipate, and I don't think any of the leaders within ASCA expect that there will be any federal support for implementation or tied to meaningful use for a surgery center EHR.
Absolutely, thank you. And then finally, I have another question here. Where is the data coming from that shows better outcomes are being reported with EHR? And are you separating the surgical centers from EP practices?
Yeah, we are, and so tied to again what you're reporting on is when that, and I had elbow surgery at a physician-owned surgery center 9 weeks ago. Great outcome. And the positive for me is or I hope I never have to go there again because my elbow is fixed. Or if I have to go there, it'll be for another orthopedic procedure just because I'm getting old. However, the quality measures that the surgery centers want to report on are those that take place within their walls or a result of their. So what's our post-op infection rate? What are the tools tied that we're following up on where we're going to be able to capture that where, hey, we reached back out to that patient 2, 4, and 6 weeks after surgery to ensure that there were no post-operative infections. So it's not going to be at the physician practice. It's going to be really within those 4 walls of that surgery center from the quality measures that we're reporting on.
Absolutely. Fantastic. Okay, and I know I just want to remind attendees we've got a couple more minutes here for a few more questions, so feel free to send those in. And I do have a few more that just came in. Chuck. First, can you please explain the difference between ScanChart and ASC Cloud?
Okay. Within ScanChart, and ScanChart ASC is our chart automation tool. Our software takes the scheduling information, the patient demographics, and with the click of a button creates your chart pack based upon the rules that you have in place tied to which forms go with that particular specialty, that physician, etc. So it automates the manual process that the staff today takes about anywhere from 5 minutes plus to create that paper chart. And then all the charting is done within the surgery center via pen and paper just like they're doing. And then at the end, the chart is scanned back into the server, and each form within that chart pack has a 2D barcode that identifies where that particular form and goes within the chart, etc. And then you have the ability to audit and see if there's any missing elements from that particular chart, so you can see that it's in there completely. So that's what ChartPack does. ASC Cloud is an electronic version of your charts on an iPad. It's an iPad application. So you're going to be charting the same way. You're not going to have any of the ChartPack creation, and you're going to chart the same way that you've been charting using forms in your format throughout your center. So that's the bigger difference is we're not going to take a foreign software, or we're not going to upset your workflow and go, hey, here's your product, change what you're doing, and you're going to use our forms. What we've done with ASC Cloud is we basically take your forms under glass on an iPad and are able to capture the discrete data so you're able to generate the reports that you want to be able to generate.
Perfect. Okay, thank you. Next, is case scheduling a typical part of an ASC EHR system, or is a separate scheduling system required?
With our system, we work with the various systems that are out there from a scheduling and billing perspective. And the dynamic there is, and this is our belief, and validated by talking to a lot of centers out there, if your scheduling and billing system works, there's not a lot of upside to replacing it. I mean, you're not going to, if your billing system is terrible, you probably already would have replaced it because you've been losing money. But there's really not a significant expense reduction and or increase in profitability tied to what you've already got in place. So what we do, and this is tied to the interoperability that everyone wants, is we take that scheduling and billing, the patient demographics and the scheduling out of your scheduling system and incorporate it into ScanChart ASC and into ASC Cloud. So, we're capturing those elements and then having, again, when you look at what you really want out of that chart pack, the key thing from a billing perspective is that operative report. You want your coders to have access to that operative report as soon as possible so they can code and they can drop the bill through their current billing system.
Absolutely. Perfect. The next question I have is, how long is the typical software buying cycle?
There's people today that are just now buying a software that I was involved with them 8 years ago. And I'm kidding when I say that, but typically with what we do at Surgical Notes, it's typically 2 to 6 months. If we're able to, if the administration understands what their need is, they've identified it, they want to eliminate those expenses or reduce their expenses, and they can convince their physician partners, it happens in 30 days. In other cases, like I said, it's a 6-year buying cycle, and hopefully we're not involved in too many 6-year buying cycles.
Absolutely, definitely. Okay, perfect. Next, I was wondering if you could speak to whether you have any recommendations for getting clinicians involved in adopting the new technology.
Number one is get them involved up front. Everybody's worked somewhere else, and a lot of folks, particularly within the surgery center market, have worked in a hospital, and the reason they're working in a surgery center is because they don't want to work in a hospital. Ask them what worked, what didn't work, and learn from that. Ask them what works about the way you guys are charting today. If you're again, 85 to 90% of the centers out there are charting on paper. Hey, what works about this? And if we were to improve it, what can we do to improve it? And I think we've identified a lot of that during the past hour. But get them involved, and ask them what they've used, and what they liked about it, and what they didn't like about it.
Absolutely. Thank you, Chuck. And let's see, we have time for 1 or 2 more questions here. Another one I have is, what is software as a service?
Software as a service is where you don't own the software. You own the charts. You own the product that is hosted by the cloud, but you're paying for the software as you go. Whereas in a purchase software license agreement, you own the software. That is your software. Now, in that, you agree to pay maintenance to support that software. But in a software as a service, you're typically going to see the acquisition cost is substantially less than if you purchased this, if you bought the software outright, or even if you did it through a capital lease. Because a lot of times, you could buy the software, but and do it on a monthly payment, but you still own it. It's a capital lease. Whereas software as a service is purely that. You could have the software from 3 years to 6 years, but you will never own the software. You're using it as a service.
Okay, that makes sense. The next question I have is, do you have any recommendations for resources to learn more about ASC IT companies?
Sure. Number one is ASCA, and also through Becker's. The June conference is coming up, and then you've got the fall conference. And a number of the companies, to include ourselves, advertise within Becker's ASC, so I would look there. And then it's state trade shows. But again, I think the June conference in Chicago is very well attended, and then obviously the fall conference in Chicago.
Perfect, thank you. And then I think the last question we have here is, do ASCs need a full EMR, or is there another solution out there?
Well, I think when you look at the products that are out there today, I mean, you've got status quo, which is paper charting, and it works. The hybrid in between is, I believe, in my opinion, is scan chart ASC. It's not going to be as expensive. It's easy to implement. It really only involves the business office staff, because for the nurses, they're still charting the way that they've been charting. So that's the hybrid product. I'm not aware of other companies that kind of have that type of a full hybrid product. I have heard of folks where they scan in their charts into they bought a scanning software, and they use that as a repository and a place to store their charts, but it doesn't address anything tied to auditing. It doesn't tie anything into chart pack creation and eliminating those expenses there. It's just simply a storage facility, as opposed to sending them off-site or having, because most centers that have been around a little while, they're out of storage space within their medical chart room.
Excellent. Well, I want to thank you, Chuck, for your excellent presentation and for participating today. We look forward to having you join us for future webinars. This concludes today's program.